This is Assessment 2 and we are looking at ensuring up-to-date training on medication administration by Sophie, Alicia, Lily, Jamie and Michaela. A medication error is a failure in the treatment process that leads to or has the potential to lead to harm to the patient. Medication errors are preventable and occur frequently in patients. It is possible to cause serious adverse effects and problems in a healthcare setting. As healthcare practitioners, we need to be able to provide safety to all patients when administering medication. Medication errors can be prevented by ensuring that 8 rights are administered to, double-checking procedures, document everything, and by checking with another nurse. Medication errors present a global problem and can lead to serious consequences, such as increased mortality, longer hospital stays, and greater costs. Factors contributing to medication errors may include lack of knowledge, as well as the administration of the medication, such as the wrong dose, route, and drug. As a team, we want to accomplish that all new and existing healthcare practitioners are up to date with medication training. Up-to-date medication training can help prevent further medication errors in healthcare and lead to improved patient health outcomes. NSQHS standards that apply to the problem include medication safety, clinical governance, and communication for safety. We are going to cover clinical governance. This standard describes the clinical governance, safety, and quality systems that are required to maintain and improve the reliability, safety, and quality of healthcare and improve health outcomes for patients. So our SMART goal. This goal is specific as we want to provide regular up-to-date training, so this can decrease the amount of errors. This can be measured by comparing the amount of mistakes made before training to those after training. This goal is achievable. This is relevant to the topic as new and existing health practitioners should have up-to-date training to prevent medication errors among patients, and it's time-bound, so we're doing it in a 3-month period. So any other health professionals that would need to be included in this project would include a tech company.
Throughout the video, it is evident that correct policy and procedures were neglected and/or not effectively communicated to staff. Dr. Campbell adopted a poor attitude towards other staff that questioned him or took too long and resulted in an increased amount of time pressures on other staff, creating a poor working environment. The shortness of staff and approval of a double procedure by Dr. Livingstone required an inexperienced doctor, Dr. Robinson, and the new doctor, Dr. Campbell, who was not yet on the IT register, to administer an intrathecal medication. Before the intrathecal procedure, the doctor's communication with Mrs. Hughes was ineffective as she was listening to her music and consequently was not informed of the procedural details. This may have given her the opportunity to flag the impending medication error. They neglected to effectively complete the 7 rights of medication administration. Both doctors were in unfamiliar surroundings with pressured circumstances, plus the assisting nurse, who was also the most experienced and familiar member, was called away during the procedure. Proceeding with the administration without the assisting nurse not only broke policy but guaranteed a medication error, as the nurse had also broken protocol by taking the medication with her in her pocket. Poor communication, time pressure, unfamiliar surroundings, inexperience, and both failure to educate new staff of policy and poor insight from current staff of the reasoning behind certain protocol led to the fatal incident. In an attempt to prevent intrathecal medication incidents from occurring again, we propose incorporating interactive online modules in the initial employment package requirements, as well as regularly throughout all staff's employment. Initially, the modules will be integrated into the intrathecal oncology unit, as seen in the video. There will be a minimum percentage pass requirement of 80%. By creating interactive modules, it requires participants to be engaged throughout the education process, increasing the information retention. After the 3-month trial of the modules being incorporated into staff's regular training, the data of near misses and medication incidents need to be analysed. Based off of the decrease in incidents and high percentage of success in the intrathecal modules, it would be appropriate to expand the implementation of our education and training modules into other specialising wards, creating unit-specific modules. By requiring staff to complete online modules before being allowed to commence work, maintains a high standard of policy and procedure, education and understanding across all levels of staff. The decrease in intrathecal medication administration incidents will be an immediate indicator of our module's effectiveness.
This intervention involves reviewing errors that have occurred due to a lack of education and knowledge on a current procedure and creating online modules which are accessible by all registered practitioner in a ward or hospital. With the use of a pre-post study, we'll be able to compare the effects of the online modules by gathering information about the number of incidents that have occurred before the modules were created and the number of same incidents which occur after the modules have been completed. We would have to outsource a tech company who have the ability to create the modules with the information provided by the hospital. We can then distribute these modules to the necessary practitioners. We would also need the staff on the specific ward to contribute their full attention when completing the modules to ensure we have the best possible outcome. A portion of the hospital's budget for training would have to go towards this intervention, as the company creating the modules would have to get paid and the practitioners will need compensation once they've completed every module. Everyone who is required to complete the modules must have access to a computer or laptop and the internet. If they do not have this at home, an alternative option shall be available on the ward. An educator will also be available to answer any possible questions individuals may have about the content being taught. This idea is to start in the oncology ward, focusing on procedures regarding medication administration and assessing for positive change. We will then be able to individualise and expand the information to other wards. Other strategies include the medication bib, which we provide a bib to be worn over the practitioner's uniform to show other workers that this individual is currently administering medication and advise them not to disturb. We have chosen to provide training through online modules as it eliminates the difficulty of finding time when all practitioners will be available for in-house training. It also empowers individuals to freely ask questions without being influenced or intimidated by other individuals.
To assess the impact of our SMART goal, we will be conducting a pre-post study. Before implementation of our training modules, we will record the number of errors that have occurred already. After all employers have completed the training modules, we would again record the number of errors related to what our goal is set out to achieve, and then compare. A comparison between the two results will allow us to determine if the training modules have had an impact on the number of errors that have occurred in the workplace. All health industry workplaces will be required to keep an up-to-date record of any errors or near misses that have occurred in the workplace that are specifically related to the training our modules are set out to educate employers on. Following the implementation of the training modules, it is expected to see a reduction in the number of medication errors made on hospital wards and in the workplace. If there was no improvement on the number of errors made, more training and information sessions would need to be implemented, targeting a wider range of areas over a longer time period, in which we would again compare pre- and post numbers. A study conducted proved that the pre-post study is highly successful. Due to the implemented training interventions, nurses' medication awareness on medication safety improved, as well as the skill to perform medication administration. Overall, this improved patient satisfaction and reduced the number of medication errors.
Spreading and sustaining improvement. Starting in one ward within the hospital, we would implement the required training for medication administration. At the start of the implemented training, we would record the level of medication errors within the ward. At the end of a period of 3 months with the implemented training, we would record the number of medication errors to see if there is any reduction and an overall improvement within the ward. If the results are positive, we would aim to move the training across the other wards within the hospital due to the improvement in the errors that have come from the training. This therefore reduces the costs that are associated with medication errors. When results keep coming back as positive, this will allow for the training to continue as there is an overall success in the training and the hospital. If the results are negative and medication errors are still occurring, more in-depth training and information sessions will be implemented. Our goal is to ultimately implement the training across the whole hospital, adjusting the training if need be to fit the particular ward. Success of the goal will ultimately reduce the errors of medication administration, which will then reduce costs of the hospital associated with those errors, leaving the patient satisfied and happy with the quality of care delivered and overall give a positive reputation of the hospital.